Good morning. Good morning, good evening, good afternoon. I always forget. Do pop your name and where you're from in the chat. Be lovely to know more about who's joining today. We've got a great session today, hopefully with lots of opportunities for questions and answers. So we'll just wait for a few more people to join and then give the interpretation instructions. Shall we go, Bruna?
Welcome to your meeting with ICM. The interpretation button should appear at the bottom of your screen, next to the Share Screen button. By clicking on the interpretation button, you can choose the language you would like to hear. The interpretation button will then transform this meeting into the selected language. To change the language you would like to hear again, follow the previous procedure by clicking on that same button. By default, you will hear the selected language at 80% volume and the original audio at 20% volume. If you would like to mute or unmute the original audio, click on the corresponding option within the language button. Enjoy your meeting. Bienvenue à votre réunion avec l'ICM. Comme la réunion propose une interprétation simultanée en français, le bouton Interprétation devrait apparaître en bas de votre écran à côté du bouton Partager l'écran. En cliquant sur le bouton Interprétation, vous pouvez choisir la langue que vous souhaitez entendre. Le bouton Interprétation se transforme alors en la langue sélectionnée. Pour changer à nouveau la langue que vous souhaitez entendre, suivez la procédure précédente en cliquant sur le même bouton. Par défaut, vous entendrez la langue sélectionnée à 80% de volume et l'audio original à 20% de volume. Si vous souhaitez couper ou supprimer l'audio original, cliquez sur l'option correspondante dans le bouton de la langue. Bonne réunion. Bienvenido a su reunión de la ICM. Como la reunión ofrece interpretación simultánea en español, el botón Interpretación debería aparecer en la parte inferior de su pantalla, junto al botón Compartir pantalla. Haciendo clic en el botón Interpretación, puede elegir el idioma que desea escuchar. El botón Interpretación cambia entonces al idioma seleccionado. Para volver a cambiar el idioma que desea escuchar, siga el procedimiento anterior pulsando el mismo botón. Por defecto, oirás el idioma seleccionado a un 80% de volumen y el audio original a un 20%. Si quieres silenciar o desilenciar el audio original, haz clic en la opción correspondiente del botón de idioma. Disfruta de su reunión.
Bienvenido. You can go to the next slide. I'd like to mention that we also have Arabic interpretation. I'm adding the instructions in Arabic on how to enable interpretation in the chat. You can also feel free to introduce yourself and share your comments during the webinar in the chat by clicking in the chat and sharing your thoughts. If you have any questions, you can please use the Q&A button that you can see at the bottom of your screen. And thank you so much. Over back to you, Kate.
Thanks, Bruna. We hope there'll be lots of opportunities for questions and answers for this session, so please do use the Q&A function. Just to start, this webinar is brought to you by the Alliance to Improve Midwifery Education. This is a global partnership of organisations looking at accelerating the progress of quality midwifery education. The webinar has been kindly supported by UNFPA this time, and also the faculty standards, which we're going to be talking about, have been kindly supported by Lardau Foundation. We've already touched on this, but do share a bit more about yourselves, what your role is, what you hope to learn today. We've got a really great lineup today of different speakers from all over the world. We've got Anna Avuglas, the Chief Executive of the ICM. She's going to give us some closing remarks. Myself, Kate, Midwife Advisor at the ICM. We've got Sarah, who's a Research Fellow from Burnett Institute and going to be talking about some research about midwifery educators. Sabira, a Research Fellow from Burnett Institute, also talking on the same topic. For those of you who were able to join last week, you might have seen Duncan, who is a technical specialist in midwifery at UNFPA. He's going to be talking on some research in Nigeria and Kenya and the role of midwife educators there. We've kindly got Jyoti joining us from the University of Samoa, who's had a big day herself, passing her PhD today. Congratulations, Jyoti. Going to be talking about some really great solutions to midwife educators maintaining competence in Samoa. And Maria Teresa from the Philippines, also talking about examples from their context. Today's topic is really close to my own heart as a midwifery educator. So we are building on the introductions to the faculty standards last week. I'm going to be talking more about how the midwife educators maintain professional competence. And that's something that, I've challenged with all throughout my career. How do we balance all the different hats as midwife educators to make sure that we are the best midwives we can be, but also we're able to provide the best quality education for the students and midwives that perhaps we teach or support. So I'm really looking forward to hearing the panelists' views on this, but also we really want to hear examples from wherever you are based. How do you manage this in your practice? What are the challenges, but what are the things that work for you so that we can share what works to many people around the world? So the outline, we're going to just recap on the ICM Global Standards for Midwife Faculty Development that we introduced last week. And hopefully some of you have had a look at those, but we'll just run through them very briefly again. We've got a really brief poll to find out what is your experiences, who have we got on the webinar today. And then Sarah and Sabina are going to talk about what midwife educators do and need to sustain midwifery practice competence. And that's from their finding from a really large global study for midwife educators. And then I've said we're going to have a panel discussion with examples from Kenya, Nigeria, Samoa, and the Philippines, and hopefully draw in lots of comments and questions from yourselves. So just to recap on the ICM Global Standards for Midwife Faculty Development, we discussed last week that there's a real need for quality global standards based on evidence around what the midwife faculty need to be able to be the best educators that they can be. And we come up with 7 different categories: leadership, partnership and collaboration, curriculum, learning and teaching, resources. Today, we're going to be really focusing on category 6, which is maintaining midwifery practice competence, and then research. And we're focusing on category 6 today because we know that is often one that is very challenging to achieve. It requires personal commitment and innovative solutions. And we're going to learn more about that through the research and our conversations today. So maintaining midwifery practice, we've had a bit of a shift in terminology. We often used to say midwives clinical practice, but at the ICM, we're shifting towards maintaining midwifery practice because we know what midwives do is much more than just clinical work, or perhaps sometimes that narrows down what others think that we do by just using that word clinical. So we've shifted in our terminology to be talking about maintaining midwifery practice competence. And as I talked about in the guidelines last week, in the companion guide, we give some examples about what that means and how you might know if you're meeting that at an organizational level, at a regional level, at a Ministry of Health. So if you're in a policy or program organizational role, these standards can really help you look at your faculty development programs and your continual professional development programs. What are the core elements that need to be included, and how do I know if I'm meeting these global standards? So before we go any further, we want to hear a little bit more about you. What is your role? Have you had opportunities to provide hands-on midwifery care in the last year? And Bruno's just going to bring up a poll now. Bruno, oh yeah, great. So should only take a couple of minutes if you can just answer this very brief poll so that we learn a bit more about who is in the chat. And what is the current context for people?
Just a reminder to scroll down because we have 2 more questions after the first one.
Oh, thanks, Bruna. Yeah, so we want to know, do you have a role in educating midwives? Have you had an opportunity to provide hands-on care? And then the third question is, would you like more opportunities to do that? And I know that Sarah's going to share that many people do want opportunities to be able to do that, but it's very difficult to achieve often with high workloads and other barriers. So we want to really focus on the solutions today around how can we meet those challenges. We've had about 70 people respond already, so that's absolutely great. We'll just give it another couple of seconds and then please go ahead and share, Bruna, the results. And we can post the results in the chat at the end as well. Let's go ahead, Bruna.
You can see the result, right?
No.
No?
You can see them, Anna? Ah, okay, fine. It must be because I'm sharing.
Okay. So do you want me to go through the results?
Yeah, do you mind?
No, it's okay. So for the first question, do you have a role in teaching midwives? 83% said yes.
Great.
And only 17% said no. For the second question, have you provided hands-on care as a midwife in the last year? 55% said no, said yes, and 45 said no.
Interesting. Yeah, so very, very, very split out there, even though the majority of people on this call are midwifery educators. Yeah, great. Thanks, Bruna.
And for the third one, do you need more opportunities to maintain your practice as a midwife to ensure you meet the ICM essential competencies for midwifery practice? 82% said yes, and only 18 said no.
Yeah, yeah, really, really interesting. And that's often what we find when we talk to midwifery educators around the world, is that we want to have more opportunities to do that, but we're not actually able to do that. So hopefully we can come up with some ideas and solutions here. And that was one of the key drivers for us putting this category in the faculty development programs, because we know that it's a critical part of our practice, but it's very difficult for educators to achieve. Great. So I'm going to now hand over to Sarah, who's going to talk a little bit, and Sabira, about their research. Thanks very much. Over to you, Sarah.
Thanks so much, Kate. Hi, everyone, and welcome. So Sabra and I are really pleased to be able to share some new global evidence with you today on what midwife educators do and what they need to keep their midwifery practice competence up to date. So the findings that we're presenting come from the Global Educators of Midwives study. This was the GEMS study that we conducted last year. And this was a study that was led by Burner Institute together with UNFPA. and it was supported by all of our fantastic partners listed here from AIME. So this has been one of the largest multi-region studies on this topic, and it's given us a really rich picture of how educators maintain their clinical knowledge and skills across lots of different countries. And just before we begin, we also want to say a huge thank you to all of the educators who took part in this study, including so many of you joining today. And, you know, it was certainly your insights and your experience that really underpin everything that we're about to share. Next slide. Thanks, Kate. Thanks. So why was this study needed? We already know a lot about the barriers and challenges that educators face in trying to maintain their clinical competence, and Kate mentioned some of these before: high workload and all of those things. And this is an area that's been very well published. But we felt that there was a very clear evidence gap, and this was especially true in low and middle income country settings. Around the solutions. So we felt that we didn't have enough real world evidence on what is actually being done by the educators in their own countries to stay clinically competent. And I think Duncan highlighted this really well in the previous AIME webinar. And, you know, certainly in his recent systematic review as well, it underscored that I think globally, there's very little practice evidence on how educators are maintaining their clinical competence in everyday settings. And at the same time, the ICM Faculty Development Standards were being launched, and we wanted to have some very practical, very good, solid examples of what educators are already doing. We wanted to know what's working well for them and also what they need to maintain their competence. And so this study really set out to fill that evidence gap. Next slide, please.
Oh, sorry.
Thanks. So our aim with this study was really to hear from midwifery educators themselves and to understand how they maintain their competence, what's working well. Also, what we asked, you know, what's making it difficult for them to maintain competence, and what systems. So, for example, educational institutions, professional associations or regulators, what they can do to also support this. And we wanted to generate some very practical guidance for countries to help them in supporting the ICM Faculty Development Standard 6. So educators were invited to participate in the study through lots of different channels. We use social media, we use the ICM newsletter, and we reached out directly to educators here through the AIME database. And then we used a mixed methods design to implement the study. So we had an online survey, and then once participants had completed the online survey, they were invited to participate in a focus group discussion. And these were both offered in 5 languages. So we had English, we had Spanish, French, Arabic, and Russian. And we really aimed through this study to have representation from all of the WHO regions. Next slide, please. Thanks. So we had a really strong participation in this study. We had 722 educators from 96 countries complete the survey. And then 33 of those educators went on to participate in the focus group discussions. And we did end up having representation across all 6 WHO regions. So the strongest participation in the study came from the Africa region, and this was followed by Southeast Asia and also Western Pacific. And the majority of participants in the study were midwives or nurse midwives. And this is something that's very encouraging because we know that ICM Global Education Standards specify that the majority of midwife educators should themselves actually be midwives. And then the remaining participants in the study also included, we had nurses, we had doctors, and also other public health professionals who teach midwifery programs. And again, I think this really reflects the reality that in many countries, they're still facing these shortages of qualified midwife educators to be teaching midwifery as well. So the participants in the study were also very highly educated. Just over a half held postgraduate degrees, and the majority were working in either public universities or training institutions. And I think what, has really stood out for us as well is that, the enormous variation in how educators actually enter and prepare for their roles as educators. I think, for example, only half of all educators stated that in their country there was any requirement for clinical experience prior to becoming a midwife educator. And when we look at that, this has major implications for how educators then maintain their own midwifery practice competence, and also how this is supported. And across the data set, we found that just close to half of all participants had worked in a clinical setting in the past year. And usually this was for a very short period of time, around 2 weeks. And it was almost always without dedicated time away from their main job as an educator, and also almost always without institutional support. So most of the educators said that they did this clinical time unpaid. It was done often after hours, or informally negotiated with a health facility, and they often did this because they really believed it was essential to remain clinically credible to their students. So, I think these numbers reflect the enormous commitment of the educators, but also the need for much stronger systems to support them to do this. So I'm now going to hand over to Sabra to take you through the rest of the findings. Thanks, Sabra.
Thank you, Sarah. Good morning, good evening, good afternoon, wherever you are. I'm going to get you through some of our key findings. Sorry. Yep, great. I thought my video is disconnected. Across all the regions, educators described a wide range of strategies, mostly informal, to keep their midwifery practice current. For example, about half of our participants, our educators who participate in this study, worked clinically in the past year, usually for short periods and almost always without dedicated time or institutional support. Most of them said they were unpaid, work after hours, or informally negotiated because they believe it is essential for them to remain up to date and also be credible to their students. In Africa and Western Pacific regions, the educators often took occasional shifts in maternity unit or arranged short clinical attachment, usually negotiated individually and done on the top of their educator workload. In Southeast Asia, many maintained private midwifery practice, which kept them involved with the labor and birth care, and sometimes it facilitated an opportunity for them to bring their students for clinical exposure to the environment. So in parts of the Pacific region, mandatory relicensure of clinical hours are provided as one of the few formal mechanisms of supporting ongoing competence in the region. Across several regions, educators describe difficulty accessing to clinical sites constantly. Like in most of the settings, simulation reported as essential, particularly in Western Pacific and Eastern Mediterranean. One educator mentioned that simulation is the only way I can keep my hands-on skills active. To stay current, educators also relied heavily on online learning, CPD modules, and other digital resources such as Lardell resources, World Continuing Education Alliance, up-to-date guidelines, and informal mentorship from practicing midwives. Next, please. Okay. So one of the clearest findings of this study is that educators maintain competence more consistently when practice is required or supported by the system. In East Africa and Pacific regions, there are regulators requiring educators to document clinical hours for relicensure. So therefore, hospitals make space for them to go there and practice, which is expected because the system support that. In parts of the Americas and Europe, educators who had a dual role with their university and hospital, they included several days in a month so they can go to the hospital and practice. One educator captured this perfectly by saying that when practice is tied to our license, we are supported to maintain it. The message is clear. System matter. Competence is stronger when expectations are formalized and supported. Next, please. So when we ask what would help the most these educators to maintain their competence, educators across all the regions remarkably give us similar answers. They want protected time to maintain their midwifery practice, and that should be recognized as part of their role, and it should be paid. So they want a structured refresher program, especially for those who have been away from practice for several years. 71% of our respondents said they would undertake a refresher program in a health facility if it was offered. They want a clear policy setting expectation for educators, clinical engagement, and CPD requirement, rather than leaving it as informal or optional. And they want regular mentorship, particularly from clinicians who understand both education and practice. Educator also noted that while simulation training is easier to access than spending time in the health facilities for clinical practice, it is not as effective as always, because those who are delivering this kind of simulation training often do not know how to deliver it or how to explain and use the equipment themselves. So institutions may have simulations resources, but educators believe that they are not well supported to use those resources effectively and confidently. Educators want those teaching simulations to be more effective and well organized. Next, please. So to just close this conversation, based on what educator told us and what we observed across all regions, 6 priority system actions emerged. First, integrate clinical practice into educator's role. Make it part of the job description and appraisal, not an optional extra. Second, establish structured refresher pathways with supervised practice for educators returning after time away. Third, strengthen simulation and mentorship, which are vital where clinical exposure is limited. Fourth, build formal agreement between training institution and clinical facilities to guarantee access and regular opportunities for educators to connect with clinical environment. And finally, align national accreditation and regulation with ICM Standards 6, so the expectations are clear for decision makers and for midwives, and ensure sustainable funding for faculty development, not ad hoc project or volunteerism. So educators are deeply committed to maintain their midwifery practice and competence. They know it matters to the quality of their teaching, for students' confidence, and ultimately for positive outcome for women and babies. But competency cannot depend on personal sacrifice only. It requires systems that recognize, support, and enable midwives to do this work for us. Thank you so much. I'm handing over to Kate for the next session.
Thank you so much. So many interesting findings there and really great solutions. What's just stood out to me is that this can't be at an individual level for an educator. It's not fair and it's not right, and that's putting too much on the individual if we want to look at improving care, safety, and quality at a system level. So thank you so much. I'm going to come off screen share in a minute, but actually there is one slide for our first speaker. So we're going to go to a panel discussion now. and hear from some country examples from Samoa, the Philippines, Kenya, and Nigeria about how midwifery educators maintain competence in their respective areas. And also then we will have some questions from the group around how people are sharing different examples, or if there are areas that you want to explore based on what you've heard. So we're going to ask each of the panelists, what does keeping practice alive for midwifery educators mean in their settings? And why does it matter for midwifery education? What does it mean for students? And what does it mean for families? But first of all, I'm going to go to Duncan and have a think about, in your studies that you've undertaken in Kenya and Nigeria, there's growing attention to linking midwifery educator competence to continual professional development. And we heard that from Sarah and Sabira around when there's regulatory mechanisms to support that, it's much easier to achieve, and countries have a process, or institutions have a process for expectation. Can you discuss a little bit, describe how this is being implemented and what a difference it's making in Nigeria and Kenya? Over to you, Duncan.
Yeah, a big thank you, Kate, and warm greetings to everyone wherever you are, and thank you for joining this webinar. Yeah, Kate, those are two questions. I'll start by the first one on keeping practice alive. Yeah, I think for me, keeping practice alive is basically ensuring that we are developing as well as sustaining the midwifery profession, and looking at three main items here. One of them being that we should be able to develop our skills and knowledge for our midwifery careers, for the well-being of our families. And the second aspect is we should be able to pass on this knowledge and skills to the next generation of midwives, so that our families then are in safe hands looking into the future. And the last thing around keeping practice alive is ensuring that as we develop these skills and knowledge, we are using the evidence-based practice so that we remain current with the latest research, to ensuring that quality of care is sustained through the evidence-based midwifery models of care that are now a global shift in terms of midwifery. And this is critical for us to ensure that we are aligning pre-service education together with the clinical practice that is happening within our setup, so that as we are training our young midwives, they are then equipped with the current skills that are evidence-based for the current practice. Now, over to the next question on what we've seen in Kenya and Nigeria around midwifery education and some of the interventions we've had. It is clear that from the multiple researches that we've had with the educators, there's clear evidence showing that educators in midwifery are inadequately prepared, both at the mid-level training colleges as well as the universities. And the key areas that we've seen majority of the gaps include the practical teaching sessions, which have also been highlighted as one of the biggest need from the study by Saber and Sarah. Then another aspect we've seen from the studies in Kenya and Nigeria is around the need for educators to be strengthened in terms of conducting assessments for the students, as well as giving effective feedback to enhance learning for our students. And the last gap that we've noted clearly is equipping our educators with the digital skills for them to be able to support teaching using the digital innovations and ICT. And these are very critical things, because when you look at the ICM Global Standards for midwifery education and the WHO midwifery educator competencies, these are clearly highlighted as core for any midwifery educator to have. And with this evidence, and from the evidence generated from the systematic review that we had, particularly in low and middle income countries, LSTM, with funding from UNFPA, we developed a blended midwifery educator CPD program, particularly targeting these educators to improve their skills around the areas that I've highlighted: the practical teaching, conducting assessments and feedback, and digital innovations for our educators. And this blended program, we had a component for 20 hours of self-directed learning where educators could complete their modules at their free times. And then we also had the 3 days residential component where we had educators from the mid-level training colleges as well as the universities, selected some of these educators from Kenya and Nigeria, completing the practical parts of this training, which were focusing on the practical teaching skills as well as the clinical skills, particularly around the emergency obstetrics and newborn care, which are essential skills that every skilled health personnel is required to have as per the joint statement made by ICM, WHO, UNICEF, UNFPA, to ensuring that all skilled health personnel are equipped with these skills so that they can be able to transfer these skills to the next generation of skilled health personnel. And we, being the first program that we developed, we had to test whether it was really relevant and satisfactory to the educators within these settings in Kenya and Nigeria. And when we had these assessments among a sample of these educators, where we had the knowledge test, the self-rated confidence, and direct observations of the clinical skills as well as the teaching skills, our educators, we reported that this was a very effective program and very relevant to their practice needs, as well as meeting their expectations as much as their clinical competencies and practical teaching skills are expected. And we saw a big improvement in terms of both their knowledge on some of the aspects that we were assessing, which were from the practical aspects as well as clinical aspects, and also the theoretical teaching. And there was a big improvement in terms of the confidence and also the skills. First, in even basic things like designing the teaching plan, which to some of the educators, these were not things that they were used to. And we expect that for every educator, this should be your bread and butter, because this is your daily life and your daily job. And apart from the teaching plan, we saw an improvement in educators' skills for them to conduct the micro teaching sessions, at least integrating these aspects of the practical teaching, student participation, teaching for the students, which were greatly appreciated by the educators. And over time, we've seen that they have been able to also utilize these within their teaching. And a key learning from this program was that the educators felt this was quite effective, flexible, and also efficient in their use of time, and also critical in improving their competencies. As I sum up on this work, it is clear to highlight some of the impact this program has had, such that although we designed the program for Kenya and Nigeria, the online version of this program is available on the WCA platform, which you can see here, the Midwifery Educator CPD program. This program has now a global access to educators around the world, and so far over 51,000 educators globally from around 60 countries are able to access this program. And we see an improvement in terms of their knowledge and skills, because we've integrated the online components for testing, the pre-test and the post-test after they've completed these modules. And we see a very big improvement and shift for those educators who are participating in this. And the last thing is that this program, with the recommendations from the educators, we were able to have it as one of the policy requirements by the Nursing Council of Kenya. And it's now an accredited program where midwifery educators in Kenya are able to access and have their CPD points, critical for their relicensure as educators. Thank you so much, Kate.
Thanks, Duncan. Great examples around how you've been able to build sustainability by linking with the nursing and midwifery council, as that's so often some of these challenges that there's good projects, but they're not able to be sustained because they don't have that the regulatory function attached to them. And once we do that, it makes it much easier. I also loved your description of keeping practice alive, developing as well as sustaining. And I think that is true, that what many midwife educators want to do, evidence-based practice, policy is changing all of the time, isn't it? And we want to make sure that we're continually offering students and our education the latest, best evidence. And to be able to do that, we need those opportunities to be able to do that ourselves. Thank you. Okay, over to Maria Teresa. So you've been leading important work at the national level in preparation and standards for midwife faculty in the Philippines. Can you tell us a little bit about the work that you've been doing there and what mechanisms or activities are in place to help educators continue building and maintaining their competence?
Okay, good afternoon, good morning, and good evening to everyone. In the Philippines, we are just lucky that we have our Commission on Higher Education, policies, standards, and guidelines for midwifery education. This paper or this document recommends what faculty development training our faculty who are teaching in midwifery, what needed training should be for the faculty to be qualified to teach in midwifery program. And then we have our Association of Philippine Schools of Midwifery, who takes the responsibility to conduct training for our faculty members. We have our collaboration with different organizations, our national agencies like the Department of Health. We have our Association of Integrated Midwives Association of the Philippines, as well as the PRC. So the era in the Philippines is very much alive. So there is always partnership between the two. And this makes that all our faculty development programs are CPD accredited. So each of the faculty who attends a faculty development program will be receiving the CPD units for each program. In developing our faculty development programs, we try to identify which of the skills, which of the competencies are needed for our faculty members who are teaching different professional courses, like the obstetrics, like the community health or the primary health care. So we need to identify what are the training needs of these faculties so that the association can already formulate a training design, collaborate with our DOH for the training of trainers. Our association, the Association of Philippine Schools of Midwifery, have our own training of trainers. So these trainers takes the lead in training our faculty members in the different areas of the Philippines. At the same time, these trainers are also trained by the Department of Health, by the Integrated Association of Midwives in the Philippines. At the same time, they are the deans, they are faculty members of our midwifery school. And one of the things that we have to be proud of, our midwifery law covers one of the required skills or competencies that our midwives should have, because it is defined in our midwifery law that all midwives should have the training on expanded role of the midwives in the Philippines. So this training entails that all our faculty members should undergo this training, the perineal suturing, the perineal internal examination during labor, the IV insertion, the injection of oxytocin. So in partnership with the PRC, the APSOM always conducts this training so that our faculty member will already be skilled and competent in teaching these skills in our students. At the same time, The simulation is always present in our curriculum. In the professional courses of our curriculum, we have the skills laboratory unit wherein students will have to practice all the skills inside the skills laboratory before they will be exposed in the clinical area. So they will have to undergo that demonstration and the return demonstration before they can really handle actual patients in the clinical area. At the same time, schools are required to have skills laboratory or simulation rooms wherein our students will be observed, guided, mentored, and coached so that when we expose them in the clinical area, they will already have the beginning competence for a student midwife. So all students who failed to perform the skills because of lack of opportunity in the clinical area or the clinical practicum area, they will go back to our skills lab to practice again all the skills that they failed to perform in the clinical area. At the same time, they are all also being evaluated using our tool. Our tool is more on competency-based tool, wherein our faculty will be observing them if they have done the procedure according to how it should be done. Then they will be advised to practice more if there are some steps that they failed to do. Feedbacking at the same time is always present in our simulation room in respective schools.
Thank you, Maria. Lots of great examples that you're sharing there. And another example of a really strong CPD system, which is linked to the national regulatory oversight to really help establish clear systems and also a standardized process is what I was hearing from you, Maria, that, the educators have a standardized program, but also based on their needs, which is really, really important. We want to make sure that student midwives all over the country are getting the same type of education, and that requires educators having the same training and opportunities to deliver it. I'm going to come to Jyoti. Jyoti, just a few minutes for you so we make sure that we've got time for questions and answers from the group. So Samoa has introduced systems requiring midwives and educators to complete or support a certain number of births and hours every year. How has this been implemented? How has this approach helped educators? So if I understand correctly, all midwives in Samoa, to maintain their professional registration, need to conduct a certain number of births and midwifery practice hours every year. Is that correct? Oh, we can't hear you, Jyoti.
Can you hear me now?
Yeah, lovely.
Okay. Yeah. Thank you, Kate, for that question. And good afternoon and good evening, good morning for everyone here. Thank you for having me in this webinar. I'm from a small island called Samoa from the Pacific. I'm a midwifery educator, and for us, we are more community-based. We are a small workforce in Samoa. So therefore, while we are in the clinic, we are supposed to work as a midwife. So when we are going for mentorship, preceptorship with our students, midwifery students, we normally work wherever we are mentoring them. So if, for example, antenatal clinic, if I'm mentoring there, I work as a normal midwife there and see almost 15, 20 mothers that day while I'm there. So therefore, that's how we are. And in the delivery, if I'm looking at the labor and delivery, I will be conducting delivery there. So that's how we managing our practices currently. But there are no specific time for us to go. There are volunteer times given for us for in between semesters. If you want to volunteer our time, we can fill in a form with the Ministry of Health, with the Chief Nursing Officer, and then we can spend. But it's not compensated or anything. So currently, the midwives also need to be, clinical midwives need to have minimum 50 deliveries for a year while they are practicing, and 40 hours of theoretical, either conference or workshops, trainings attended for normal clinical midwives. That's the regulatory process for annual practicing certificate. And it's the opposite for us. For midwifery educators, we need to have minimum 30 hours of clinical practice, minimum 5 deliveries conducted, and 2 times biannually we need to be doing PEMNET. PEMNET is like a credentialing program, which is the Pacific Emergency Maternal and Newborn Training, which is introduced a couple of years ago, maybe almost 10 years. And that is part of the APC. So if we have not gone for the PEMNET training, that means we are not credentialed, and maybe we will get cancelled our annual practicing certificate. So therefore, this is very important for all the midwives and midwifery educators to complete the PEMNET as well as the hours. And that regulatory process actually helping us to do this. But at the moment, we are actually also working on, our national university is working on an MOU between the Ministry of Health through the Nursing and Midwifery Council, whereby 0.2 of your work will be done in the clinical, and 0.8 will be at the National University, and the opposite to the Ministry of Health. So if you are a midwifery clinical midwife, 0.8 will be in clinic and 0.2 will be teaching. So it will help both ways. So their clinical experience can be taught to the midwifery students in the university, while we do 0.2 at the clinical. So therefore we can achieve those hours as well as the delivery while we are there, and it will be paid. So for example, 0.8, the whole 100% will be paid by the National University for midwifery educators, but our 0.2 will be at the Ministry of Health, and vice versa for the clinical midwives.
Thank you, Jyoti. They're absolutely fantastic examples from Samoa. That sounds really exciting, and I'm sure for many educators, what an opportunity to have that, to be able to have that balance. But like you've rightly said, also developing sustainability and future midwifery educators by enabling clinicians to come into the university and provide that education to students, because we hear from students so often about the practice theory gap, don't we? And what they're learning in universities or institutions is not what they see in practice. And that credibility of their educators and that real lived experience of educators being able to share examples from their practice is so important for students. So I love that integration of education with practice, and that is so important. And I think Samoa's got a really good example there. I wish you all the best in getting that through, and we'd love to hear more about that in the future. I'm just going to come to a couple of questions now, because we've got some really great questions in the chat. A question from Famina. Can you explain about accreditation of faculty members? How can they be assessed? You might want to have a think about the ICM's Global Standards for Faculty Development. The ICM also has the essential competencies for midwives, but it's important that these are locally assessed and evaluated. We've heard some good examples here today about, right at the very start, requirements for educators to be midwives and that they are practicing midwives. Sarah and Sabina's study showed that in about 50% of cases, maybe the people that are midwife educators had never practiced clinically. And so, that's going to be a real challenge around whether they are able to maintain their competence. And I know in many settings, or some settings around the world, it's taken real courage for midwife educators who maybe haven't had that expectation in the past to go back into practice and really learn and develop those midwifery skills. And I really applaud those midwife educators that have done that, because that is a real strength to be able to go back and learn those skills at different points in your careers where maybe you haven't had to do that before. And that was often some of my experience of midwife educators in India. It took real courage for nurses to go back, who have senior lecturers, to go back into practice and relearn those skills as midwives. And but that also requires an expectation to be able to do that. But well done for that. I don't know if anyone else can see any other questions that would be good for the group. Duncan, this is one just for you. How can someone access that CPD program that you were talking about? I know you briefly discussed it, but do you want to just talk about where people can access that?
Yes, thank you so much, Kate. So when you go to WCA platform, the World Continuing Education Alliance platform, this is an organization that offers online learning. You will find among their programs, we have that specific program called the Midwifery Educator CPD program. Maybe Kate, if you could kindly reshare the slide, that's exactly how it looks on that WCA platform.
Yeah, maybe Bruno might be able to drop the link into the chat. And then Geld had a question around how can ICM and member associations enhance educational opportunities for midwives towards MSc and PhD programs. This strengthens and motivates midwife educators. Very good question, something that we were talking about yesterday, Anna. I don't know if you've got any comments on that.
I lost you there for 2 minutes. Sorry about that. Come back again.
We had a question from Geldwas about how can ICM and member associations support educational opportunities for midwives towards MSc and PhD, as this really strengthens and motivates midwives and midwife educators. And I said we were actually discussing about this yesterday, so I didn't know if you had anything to add there.
No, thank you, Kate. Sorry about that. My internet's coming and going. It's really, really important that we start to have these discussions because we do see attraction from many countries to advance from the diploma level or post-nursing programs into higher academic education ladders, so to speak, for not only the students and the graduates, but also more importantly for the midwifery faculty, because we really need to sustain that into the future with a good academic level. So we are discussing it, and hopefully we will work more on it in the next year as well. Thank you, and back to you. And sorry about the internet again.
No. So I'm just going to leave with one comment from Jacqueline, who's our chief midwife, and then hand over to Anna for close. But Jacqueline's comment was that it's incumbent on leaders and decision makers to advocate for the essential role of midwife educators in maintaining contemporary clinical practice. Education institutions must recognise that teaching and practice are inseparable. Competent midwifery lecturers cannot exist without ongoing engagement in midwifery practice. Establishing this as a requirement from the outset ensures it's fully acknowledged and supported by the education provider. And I think that's a really good comment to close with. We've heard that in the research and in these other examples that we need systems that are supported at ministry and regulatory level about the requirements of midwife educators, so it's not left to chance, and we don't leave the quality of midwifery education and midwife educators to chance, and instead we're working towards a process that is fair and equitable for all. So thank you very much to everyone. I'm going to hand over to Anna for just a couple of closing comments, and I'll just reshare the last slides.
So much, Kate. It's been really a second very, very vibrant webinar on midwifery education, focusing on the midwife faculty. Thank you to every one of you who have participated today. I see that we have been just over 220 members here, and in the chat you would have seen also the sharing of the recording from the last webinar we had last week, and we will absolutely share this one as well. There is a YouTube channel on World Midwives, and please share widely and revisit the recordings again, because I think there is so much here to learn from and to get ideas from and to build upon. So we revisited the ICM Global Standards for Midwife Faculty Development, and we were so pleased to hear from Kenya, Nigeria, Samoa, and the Philippines. Thank you so much for sharing your insights, and given the chat that is ongoing constantly, there is a huge interest, and that makes us and me myself personally burning for this, very, very happy, because I think this is the dialogue we need to have at global level. The midwifery faculty is really, really central to education quality and to better outcomes for women and for newborns. So this is why we do this. And it's also for the future of our midwifery programs all over the world. And this is very much in line with where we are heading to absolutely help the women, mothers and babies to survive and thrive, supported by the hands of midwives, absolutely. What I do hear a lot of challenges around staying clinically updated, keep on with the practice. And as we saw, 82% said that you need more opportunities for maintaining your practice as a midwife to ensure that you meet the ICM essential competencies. And I think this is really a very important signal to all of us to keep on working on this. I'm happy to hear that simulation was reflected as one of the pedagogical methods to uphold clinical skills and practice, but also to use the evidence that we have to date, and also to discuss more at institutional level how to maintain and how to develop this. The next steps would be to really make the best use of the ICM standards to review and to strengthen all of our programs in the world, and to actually keep on the discussions within your institutions, associations, and regulatory bodies. And then to contextualize and adapt to your own context. That's really, really important, and the standards are designed to be flexible. The AIME Alliance, all of us remain committed to support this work, and we invite you to use all the resources that has been shared today. And then we have the petition to sign for 1 million more midwives campaign. And please feel free to use the QR code in the slide. And in the upcoming holidays, we have challenged our ICM staff, but we also challenge all of you to share the petition and to sign up for as many as we can. Today, we have 14,000 signatures. We are striving to a very high goal of 1 million, but we really, really hope and urge you to share with family, with friends, with colleagues, to sign up to a course and to actually have midwives, which is a concern to every single one of us, and especially you being educators and clinical preceptors to engage in this. With this, I really want to thank every single speaker and all the ICM head office staff that has been working diligently in the background. You know us by now, and I'm really, really grateful for that. I'm wishing you all a good ending of 2025 and look forward to a very exciting 2026 together. Thank you so much, and back to you, Kate.
Thank you all. Really fantastic webinar. Stay tuned to AIME and the ICM and the other organisations for updates next year. And do let us know how you're finding the faculty standards, how you're using them. We always love to showcase different examples in our newsletter and in other ways. So thanks very much. Have a great end of year, and we'll see you all in 2026.
Kate, there's a very good question. Can students also sign this petition?
Yeah, I've responded. Yes, as many people as possible, family, friends, sisters, brothers, anyone. As we always say, everyone was born, so everyone hopefully supports midwives.
Excellent.